Thank you very much. That was very, very informative. I will say, over the years that I've been doing this, being able to reach community physicians has been a real challenge. And I think one thing our colleagues at NTMir are doing, which I think is potentially very transformative, is they're making a huge effort to bring education about NTM and bronchiectasis to more physicians in the community. Because I don't think, we as at meetings and so on have not been effective at doing that. So hopefully, I hope their efforts are going to pay off. Our next speaker is Rachel Thomson from Australia. And Rachel, you may get the award for the longest flight. Thank you very much for coming. Rachel is going to talk about something I know that's of interest to everyone as well, environmental factors in reducing exposure. Rachel.
Thank you, Dave, and thank you everyone for coming today. It's great to see such a big audience for NTM. It's really changed over the years and it's wonderful to see. And thank you to the organisers for inviting me to come all this way. These are just my disclosures, which are not relevant today. So we've all known for many years that NTM are widespread in the environment. And it's really only been in recent times, or relatively recent times, that we've become quite interested in where they're coming from, because, as we've already heard, disease is increasing and we want to know how we're getting these infections. And so there have been a lot of studies done, and probably more studies that need to be done. And we have found NTM in household and hospital tap water, bathrooms, potting soil, garden soil, and all of these have been identified as infection sources by matching the genotypic profile of both clinical and environmental isolates. And the routes of transmission include both water and soil, and also cough aerosols. It's been said that in wine there is truth, in beer there is strength, and in water there is bacteria. But what is the evidence for this statement? And I think we really need to critically look at the evidence. There have been a wide variety of NTM species identified in water samples, but not all of these have been associated with disease. And as I mentioned, we need genotyping of strains to identify patient isolates that match with these water isolates. And this has been done with household and municipal water systems for avium, abscessus, Kansasii and lentiflavum, and for hospital water for porcinum, avium, abscessus, fortuitum and chimera, but importantly not for intracellulari. So how does this work? This is a schematic diagram of what's happening with our water supply. Oops, I don't know how I did that. So you can see in most cities around the world there is a source water, which can be a groundwater, it can be underground water. And this is pumped to a treatment plant where the water is filtered and disinfected. But the hardy mycobacteria tend to attach to the filter media and form a biofilm on this media. And inside that biofilm, the organisms grow and proliferate. And they survive the disinfection because they are many times more resistant to chlorine, chloramine, and chlorine dioxide that are commonly used in most disinfection plants. In the pipes, more biofilm forms as we've travelled down the distribution system, such that by the time the water gets to our taps, the concentration of mycobacteria can be 25,000 times what comes out of the treatment plant. And this is because the organisms are growing within the biofilm inside the pipes. And this biofilm formation is much more significant in smaller diameter pipes and where you have very complex plumbing arrangements, such as in more urbanised areas and with big buildings. The NTM also survive within the system inside amoebae, and the amoebae provide a vehicle for replication and transmission, And in some studies, there's suggestion that it actually enhances their virulence and protects them from the disinfection. You can see in this diagram here, there are 6 different types of amoebae, and you can see the little acid-fast bacilli growing within them. The mycobacteria are then released into the water from the biofilm by transient pressure events. So when you turn on and off the tap, the sudden changes in pressure result in a release of the biofilm into the water, and so you get varying concentrations of mycobacteria released at different times. And this occurs more significantly in smaller diameter pipes. Biofilm formation also occurs on the point of use connections. So those little tiny mesh things that are screwed onto the end of the taps provide a great medium or area for biofilm formation and for the organisms to grow, so that when you turn the tap on, you flush out the mycobacteria that's been growing on those pipes. These in-fridge water filtration systems, or some of them don't have filtration, they're just a means of refrigerating the water. They're also a great source of mycobacteria. So if the mycobacteria are present in the water, we can either inhale them through aerosols or we can aspirate them. And aspiration has been shown to be associated with mycobacterial disease, not only through patients who have gross reflux, but also for patients who just have minor reflux that can occur during sleep. And it's thought that it doesn't take too many bacteria to actually cause infection in the host. And normal people can aspirate. Normal people aspirate at night, every night, but have clearance mechanisms for getting rid of these organisms. The ability for mycobacteria to form aerosols is very important in terms of its transmission. So mycobacteria are inherently hydrophobic, which means they can naturally aerosolize from the water into the air. And this has been shown in some really quite old experiments now from the 40s and 50s, where petri dishes were floated upside down over natural water sources, and the mycobacteria were grown on those petri dishes floating in the water. And this aerosolization can cause a 1,000-fold increase in the number of mycobacteria per mil of water. And you can see from this diagram here the size of the bacteria, the size of the aerosol that is needed to get down to the alveolar duct area right at the end of the airways in the lungs is around the 1 to 5 micron, and this is the size of the droplets that mycobacteria can form. And the evidence for water aerosols first really came to our attention when there were reports of hot tub lung that emerged. And this was a form of hypersensitivity pneumonitis, not the standard infection, where patients who had been using hot tubs were inhaling quite high doses of aerosols and developing almost an allergic reaction in the lung. And this has been reported in lifeguards and pool attendants also who work in indoor pools where there's a lot of sprays and waterfalls. It's also been reported in metal workers whose water had been disinfected but immunogenicum had overgrown. These bioaerosols have also been studied recently in the natural environment, and this is quite a cool demonstration of how natural bioaerosols that happen during rain can disperse organisms around the world. And they essentially looked at raindrops impinging through a very small diameter and looked at the trajectory of these raindrops and how far they were able to spread bioaerosols. And the brightly coloured pictures there, I don't know if I can use this, whether this will... you can see the little tiny bacteria inside a magnified droplet of water or aerosol that can be transported by wind to very significant distances around the countryside. And it's estimated that this transmission of organisms is quite significant following thunderstorms and heavy rain and may account for some of the geographic distribution of our infections. These aerosols are also important for showerheads, and there have been quite a number of studies, both here and in Australia, that have demonstrated mycobacteria in showerhead biofilm, and also the growth of mycobacterial aerosols from the steam that is generated during showering. And this is most important for avium abscessus and Kansasii. But importantly, as I mentioned earlier, Mycobacterium intracellulare has not been isolated from water or been implicated in water aerosol transmission. Previously, the studies that had thought Mycobacterium intracellulare was in the water used older techniques of identification, and with our more modern techniques we've been able to show that the MAC complex is actually quite a number of different subspecies, including Avium intracellulare, but also Chimera and the other ones you see here. And Mycobacterium intracellulare is thought to be more associated with soil and dust and not a water pathogen. This is an example of the genotyping that I mentioned, and essentially for the lay people in the audience, genotyping involves assigning a bacterial barcode, similar to the barcodes that you see on items in the supermarket. So each bacteria has its own unique barcode. Some barcodes are identical to others, and what we need to show is that the barcode of the water isolates is identical to the barcode of the patient isolates in order to show that there is environmental and clinical matching. And this is a schematic here of the abscessus isolates that we had in the water. The arrows are pointing to water isolates, and the other isolates are patient isolates. And you can see there are two different patterns there. CP17 is a clinical pattern, CP15 is a clinical pattern, and in those patterns there are water isolates that match. Soil has also been implicated in NTM transmission, and this study on the right here was one of Marianne de Groot's studies that showed quite a variety of NTM isolates in soil. And then the Japanese have equally looked at patients with avium and intracellulare on the left here, and looked at the avium and intracellulare isolates from their own soils. And you can generate aerosols by pouring of soil and potting mix, and there have been at least 3 studies that have correlated soil exposure with NTM risk. This is the first of those studies where a number of patients with MAC, predominantly intracellulare, were surveyed for different activities that might have increased their risk. And because this study was done predominantly on intracellulare patients, you can see up the top there that soil occupation and farming, farm truck drivers and landscapers all had an increased risk of MAC disease. But those who participated in the water exposures didn't show an increased risk. Those results might have been different if the predominant organism was avium or abscessus. And it has been shown that the number of years that you participate in a soil-related exposure or activity increases the risk exponentially. Dust particles are also significant, and they're commonly suspended in the air so that they can be inhaled. In a study done in the early 70s by my colleague David Dawson, he collected 120 strains of NTM from vacuum cleaner dust in Queensland. 50 of those strains were intracellulare, and 44% of those belonged to serotypes that were recognised disease serotypes from patient samples in the lab. More recently, this was a sequencing study that looked at quite a wide variety of strains that could be identified in house dust. Fomites are inanimate sort of particles that live on surfaces in everywhere, essentially. This is a study that most of you will be aware of from Cambridge, which looked at the spread of abscesses through a cystic fibrosis unit. And this looked at one single room where 4 patients sequentially inhabited a room. The first patient, as identified by the red dots, had smear-positive, culture-positive abscessus and went into a room for treatment for some months. The patient underwent treatment, came out smear-negative, culture-positive, and then further patients 2, 3 and 4 also used that room. They went in with negative samples but came out and soon after developed positive samples. And eventually the penny dropped. The room was sampled and environmental samples were positive for abscesses. The cleaning regimens were changed, and subsequently there weren't any further transmission events. But this then led to some further work to look at how this could happen through the surfaces in the room. And some studies were done that demonstrated abscessus can survive within fomites and that it physically associates with these particles. So on the right-hand side, there are 3 graphs. The first you can see the black curve is without dust. The blue curve is with kaolin, which is found in clay, and then the orange is house dust. And you can see that abscessus growth is highest when it's associated with house dust than when it's just on its own. And then the bottom curve shows you that even after 2 weeks, the abscessus organisms can survive desiccation, and that this shows that abscessus actually, the growth is enhanced through growth and drying periods by the presence of kaolin or dust. So if these organisms are everywhere, how can we control our exposure to them, and why should we bother? It's important that we prevent new infections in susceptible patients, and we prevent reinfection whilst on treatment and after completion of treatment. We've seen from our colleague Richard Wallace that recurrence rates are up as high as 30 to 50% after apparently successful treatment, and this is really unacceptably high. You go through a hard course of treatment and you hope that you're cured, only to become reinfected with a new strain. And it's been shown that most recurrences are new infections with different strain types, or of the same species or of different species, and so therefore it's important to know how we can prevent reinfection. But there's a lot of evidence we don't have. We don't know what the exact route of acquisition is in an individual patient. We can suspect it based on the history we take, their exposures, but we can never really pinpoint in time or place when a certain patient actually acquired their infection. We also don't know how much exposure is necessary. Can one shower give you infection with NTM? Do you need to have repeated exposures? And what is the impact of where we live, of climate and industry and other activities in the world around us on the background level of NTM in our society? And finally, there's no formal studies that have ever shown that any intervention will reduce your exposure. And these studies are quite difficult to do, and therefore we should just prevail with common sense. And I believe that any intervention that's simple, cost-effective and easy to implement and has some evidence base in theory should be considered. A simple thing we can do is to flush the taps. So stagnation of water in the pipes that lead to our taps has been shown to increase NTM in first catch samples. And this can simply be overnight stagnation. So if you have a tap in your house that you hardly ever use, you should probably flush it for 5 minutes before you use the water from that tap. But if you've got taps that are used on a daily basis, then a shorter flush on the first use of the day is recommended. Take off the mesh aerators. We've already discussed how mycobacteria are attached to these things. They form biofilm and they proliferate, and the number of mycobacteria coming through these taps is much greater, and therefore removing them may help. Try and avoid point-of-use filters because the mycobacteria also attach to the carbon within these filters. They grow in the biofilm, and the water passing through these devices is significantly more concentrated with NTM than without. They do work for about 2 weeks, so if you want to use them to filter other things out of the water, then you need to change the filtration cartridges very regularly, and this can be quite costly. Similarly, these underbench or pre-tap water filtration systems also enhance the proliferation of mycobacteria. And if you look at the websites that promote the use of these things, they will say removes 99-point-something% of bacteria from the water. Well, the point-something that they don't remove are the mycobacteria. And in fact, by removing everything else, they free up the environment for the mycobacteria to thrive, and so it creates quite a nice environment for them to proliferate. If you're going to use them, you need to maintain them adequately, and that can be quite annoying and repetitive, and we all forget. You need to change the cartridges. They say, the manufacturers say to change the cartridges every 6 months, but realistically for mycobacteria it has to be much more frequent than that. And so I generally say avoid these sort of systems. Similarly, there have been on the market now some systems that promote UV disinfection within the plumbing systems. So you can put these things into the plumbing in your house, and it's supposed to generate UV that kills the bacteria travelling through the water. But the doses required to kill mycobacteria and the time of exposure that is needed to kill mycobacteria is not sufficient in the currently marketed devices. The simplest thing you can do is turn up the hot water system. Leah Landy and Richard and others did a nice study in the Philadelphia area that showed that patients whose hot water systems had been turned down had a much greater incidence of Mycobacterium avium infections. This graph shows the temperature sensitivity of both Sanopi and avium, and as you turn the temperature up to 70 degrees Celsius, the ability for mycobacteria to grow is significantly reduced. In Australia, it's mandated that hot water systems have to be installed at least at 60 degrees Celsius, that's 140 Fahrenheit. Many can heat up to 75 or 80 degrees, which will scald you within a minute. And so a lot of people have turned down the systems to avoid scalding both in children and in the elderly. But really what you need to do is have the water stored and the tank level at 60 plus, and have your tempering device or mixing device at the tap, not further back in the system. So if you have a tempering valve that comes out of the hot water system so that by the time it gets to the tap it's cooler, the plumbing that it has to pass through will allow mycobacteria to grow. So you need to have these tempering devices at the tap and have the hot water stored at the highest temperature you can. You can replace shower heads. The plastic shower heads are more prone to biofilm formation than the metal ones. It's been promoted to soak the shower heads in vinegar for 60 minutes, and as you can see by this diagram, you don't actually have to be able to take the shower head off. You can hook the vinegar around the shower head in a plastic bag. It's been said to repeat it at least every 6 months, and this is probably realistic in terms of our time management, but you probably need to do it a bit more often than that. Some have recommended household bleach as an alternative. However, there's been at least one study that's shown that if you do bleach NTM, over time they become more resistant to the chlorine, and then that can then create more resistant organisms. Ensure adequate ventilation in the bathroom. A lot of patients with NTM don't have a lot of body fat to insulate them against the cold. And when I did my home sampling study, I was surprised by how many patients who told me that they get in the shower, they shut the door, they don't open the window, they don't use the exhaust fan because they get too cold. And it results in a large buildup of steam within the room, which then is further concentration of organisms for them to inhale. So make sure you use the exhaust fans, change the filters on the exhaust fans as frequently as the manufacturer tells you to, leave the windows open and ensure adequate ventilation. Nebulizers should be cleaned after every use, which is time-consuming and tedious, but nevertheless, if you use one of these baby bottle type sterilisers, it's quite simple. You just put the stuff in and put it in the microwave or switch it on. Some of these electric steam sterilisers work well. You can place it in boiling water and boil for 5 minutes, or use just a microwave container with boiling water. If your dishwasher goes to over 70 degrees Celsius, you can put the nebulizer parts in the dishwasher. Other devices which may generate aerosols include CPAP humidifiers, a very common cause of NTM referrals in my part of the world, people using all sorts of water in those. Neti pots, nasal rinse devices, humidifiers, even the steam irons can all aerosolise NTM, and the use of sterile or boiled water in those devices is recommended. Avoid indoor pools, hot tubs, steam saunas, hydrotherapy pools, and other activities where you may have high concentrations of NTM aerosolised. For those that have reflux, and even those patients who aren't aware of reflux, it's not to say they don't have reflux, it doesn't hurt to take precautions to make sure that at night there is as little reflux as possible, and this may mean obtaining a foam wedge at 30 degrees so that you can sleep elevated. It's not appropriate just to use a couple of pillows because A, it's bad for your neck, and B, it doesn't really work. Making sure that you wait at least 3 hours before going to bed after having the evening meal, and having small meals more frequently. There have been no studies examining the effectiveness of masks in gardening, and I know a lot of our patients garden, but even in the absence of evidence, I don't think it hurts to recommend that people who like to work in dusty activities use some personal protection. Moistening the soil or the potting mix before you pour it and generate aerosols can also reduce the amount of particles that you're likely to inhale. So to summarise, NTM causing human infections can be found in quite a wide variety of environmental sources, but the environmental niche may be species specific. For example, the difference between avium and intracellulare and even abscessus. We've heard a bit about geographic variation in species distribution, but this is not only in the patients but also in the environment. Our human activities may influence the number of mycobacteria in the environment, for example, things that are happening in agriculture and water disinfection practices, and this may increase exposure, but also activities that we partake in can increase our exposure, for example, hot tub use, gardening and house dust. The aerosols generated from mycobacteria are of a respirable particle size, and this can be from showering or pouring potting mix, and these can then be inhaled. Mycobacterium intracellulare is the main pathogen responsible for NTM disease in a lot of parts of the world, and it's important to remember it's not been found in water, but it's mainly soil and agriculture. There's been no evidence that showering frequency is associated with NTM disease, and therefore I'm not an advocate of telling people not to shower. And it's possible that climate change and natural events are more likely to influence the mycobacterial numbers in our environment, and we clearly need a lot more work in this area. And on that note, I will stop and be happy to take some questions.
Thank you. Actually, we're going to have faculty Q&A afterwards. So
okay.
Right now there's a break. If you go down the hallway to the exhibit hall, down the hall to your left, there are snacks. And also, while conference is in session, on either side of this room, there's water, soft drinks, coffee, and tea available if you'd like. Thanks.